Cynthia, a case study in multiple sclerosis. MS is an inflammatory disease of the central nervous system primarily caused by the destruction of the neural myelin sheath. The disease results in 5 to 10 years reduced life expectancy and affects about 30 people in every 100,000 around the world. This figure depends on many factors, including ethnicity and gender, and the disease onset is usually between 20 and 40 years of age. There is also a genetic predisposition to the disease. In those with a first-degree relative who has MS, there is a 15-fold increase in their chances of developing the condition, and this is thought to be due to changes in the human leukocyte antigen DR2 haplotype on the long arm of chromosome 6. This group of genes encodes for cell surface antigen-presenting cells, and it is likely that changes in the function of these genes alters the essential activities of the immune system. MS has a wide range of symptoms as shown in this diagram. The immune system largely determines the pathophysiology of MS, and in the case of the innate immune system, MS is influenced by the effector function of T and B cells. Regulatory T cells, when activated by toll-like receptors, produce an array of inhibitory cytokines such as IL-10 and TGF-beta, and T cells also differentiate into either Th1, Th2, or Th17 phenotypes, and Th1 cells are pro-inflammatory, while Th2 cells are anti-inflammatory. The adaptive immune system is active in MS by initiating the presentation of a specific antigen to T lymphocytes. The interaction between antigen-presenting cells and T cells is a chief component in the initiation of the adaptive immune response, and several types of T cells can be activated by APCs. Th1 cells and Th17 cells are both pro-inflammatory and migrate to the central nervous system to cause demyelination and axonal loss. B cells and their products are also involved in the pathogenesis of MS. B cells can make antibodies which are present in the CSF of MS patients, and in addition, B cells are known to produce pro-inflammatory cytokines. The demyelination of neurons appears to occur in two phases. First, structurally abnormal areas appear in the brain and spine, followed later by leaks in the BBB. MS is mainly a white matter disease, and lesions appear primarily in periventricular areas. However, the cortex and deep grey matter nuclei are also affected. Scars build up around damaged axons as the demyelination and compensatory remyelination process continues over long periods. Changes in MS tissues can also be seen, and these are listed here. This light microscopy image shows areas of myelin loss and scars caused by multiple MS attacks. Cynthia's symptoms are primarily physical. However, other common symptoms experienced by MS include those which can be classified as mental and those that can be classified as psychiatric. Several MS subtypes have been described, and they are important not only for prognosis but also for treatment decisions. Relapsing remitting is the subtype initially experienced by 80% of patients, and it is characterized by unpredictable relapses followed by months to years of remission. Cynthia's case history is described here. It is likely that Cynthia is experiencing secondary prognosis MS, as shown in this diagram. A diagnosis of MS is made using a combination of presenting signs and symptoms and clinical assessments. The McDonald criteria, which use clinical, laboratory, and radiological evidence of lesions, is the most commonly used method of diagnosis. MRI of the brain and spine, which would likely show demyelination, as well as testing of the CSF, which can provide evidence of chronic inflammation in the central nervous system, and finally, evoked potential testing, which would likely show slower stimulation of various sensory nerves, are the clinical assessments used to diagnose MS. As mentioned, the McDonald criteria are commonly used, and these include 1 year of disease progression plus any two of the following: a positive brain MRI, a positive spinal cord MRI, and positive CSF results. In MS, demyelinated areas have become scarred and formed plaques which show up as hyperintense images on MRIs due to the dense nature of the tissue in the area. In some cases, plaques may lose myelin and blood flow completely, which results in a black hole image on the MRI scan. Gadolinium can also be used intravenously prior to an MRI scan, and this contrast medium allows active areas of attack to be differentiated via MRI images. Note the image on the right, which shows plaques. In testing CSF, a sample is removed from the intrathecal space via lumbar puncture and is tested via electrophoresis for the presence of oligoclonal bands. These are bands of immunoglobulins, particularly IgG, and the presence of these bands, along with the absence of these bands in serum, indicates that immunoglobulins are being produced in the CNS. This test also allows investigators to rule out other conditions. The image shows typical result obtained via gel electrophoresis of CSF from an MS patient. On the right, the oligoclonal bands can be clearly seen, indicating inflammation in the central nervous system. Finally, evoked potential testing can help diagnose MS. These tests measure the electrical activity in the CNS in response to stimulation of specific sensory nerve pathways. Any latency in electrical conduction caused by demyelination will be detected. Examples include visual evoked potentials, which assess the visual pathway, brainstem auditory evoked potentials, which test the auditory nerve, cochlear nucleus, superior olive, and inferior colliculus of the brainstem, and somatosensory evoked potentials, which are elicited by tactile or electrical stimulation of a sensory or mixed nerve in the periphery. Wires are placed on the scalp overlying the areas of the brain being stimulated, and the examiner then provides specific types of sensory input and records the responses of the person's brain. In brainstem auditory evoked potential testing, the patient hears a series of clicks, while with visual evoked potential testing, the patient views alternating checkerboard patterns. And finally, in somatosensory evoked potentials, some form of stimuli is administered to a limb. This image shows the results of a visual evoked response test. The top conductance line, which is from the right eye, shows normal neural conductance speed, while the response of the left optic nerve, as shown in the lower of the two lines, is delayed, indicating impedance in the optic nerve. Cynthia has an 18-year history of disease, meaning that there has been significant time for demyelination and scarring. As such, black holes and plaques will both likely be seen on her MRIs. In addition, Cynthia reports recently having a cold and suffering from a current attack. This would mean that there is active MS inflammation and destruction, which would show up if using gadolinium contrast medium. MRI results from Cynthia's tests could show all of these images. With regard to testing of Cynthia's CSF, it is likely that oligoclonal bands positive for IgG would be detected. This is due to Cynthia's recent symptoms, including numbness and fatigue, all of which indicate a current attack. Cynthia has recently reported experiencing dizziness, and the fluid-filled structures of the inner ear are largely in control of our sense of balance, so it is highly likely that Cynthia would demonstrate reduced neural latency in a BAEP test. Cynthia may also record latency in other sensory pathways, even without clinical indicators of disease. Cynthia has also described experiencing a sensation of electrical buzzing with cervical flexion. This is the diagnostic feature of Lermut's sign, and it's caused by inflammation in the posterior columns of the spinal cord. Fatigue in MS likely results from changes in the immune and central nervous systems, including pro-inflammatory cytokine production, endocrine influences, axonal loss, and altered patterns of cerebral activation. High levels of cytokines, such as TNF-alpha, and hormones, such as ACTH, have been found in the central nervous system of MS patients, while decrements in glucose metabolism have also been reported. Additional mechanisms contributing to fatigue may include sleep disorders, depression, and iatrogenic mechanisms, or the effects of medication. These include antispasmodics and pain medication, which can cause fatigue and drowsiness. To demonstrate the impact of MS on fatigue, Sheehan and colleagues measured strength in the adductor pollicis muscle. They showed normal baseline strength in MS patients, but a greater strength decline over time compared with controls, and these investigators suggest that cervical cord recruitment changes likely contribute to fatigue. Further work by Vucic and colleagues suggests that activity-dependent conduction block as a result of axon membrane hyperpolarization could contribute to the mechanism of fatigue. These authors found dysfunction in the sodium-potassium pumps, along with secondary axon degradation leading to rising calcium levels, largely as a result of reversed sodium-calcium exchanger function. In terms of treating MS, there are a number of goals a GP is likely to aim for, and these include reducing the frequency of disease relapse, relieving symptoms, and repair of damaged tissue, while secondary treatment goals might include maintaining motor function, maintaining autonomic nervous system function, and relieving pain. In addition to drug-free therapies, there are many pharmacological agents available for MS treatment. Immunotherapy drugs such as those listed here are important as they slow the frequency and severity of attacks and the amount of myelin subject to damage. Interferon beta 1A and 1B are both cytokines which produce an 18 to 38% reduction in disease relapse rate. Interferon beta balances the expression of pro- and anti-inflammatory agents in the brain while reducing the number of inflammatory cells that cross the BBB. Therapy with interferon beta leads to a reduction in neural inflammation, and moreover, it is thought to increase the production of a nerve growth factor and thus reduce neural death. Glatiramer acetate is a polymer of 4 amino acids, which may work as a decoy for the immune system. The resemblance of glatiramer to myelin basic protein is suggested to divert the autoimmune response away from myelin. Another class of drugs commonly used in MS are the immunosuppressants. These are medications or substances that suppress the body's immune response, and in MS they are given during a relapse to stop the patient's immune system from attacking their myelin and to reduce inflammation. Mitoxantrone is one of the immunosuppressant drugs used in MS. It suppresses the proliferation of T cells, B cells, and macrophages, and impairs antigen presentation while decreasing the secretion of pro-inflammatory cytokines. Mitoxantrone is most effective in secondary progressive MS, and while it is not a cure for the disease, it can reduce the overall progression of it. Corticosteroids are also widely used in MS. They inhibit lymphocyte proliferation and the synthesis of pro-inflammatory cytokines. Today, corticosteroids are standard treatment during acute relapses, and while there is no evidence that corticosteroids slow or reverse disease progression, they may reduce disability progression. Finally, in addition to the 3 classes of drugs described previously, anti-seizure drugs may be prescribed to help control Lermit sign symptoms as well as MS-associated pain. Steroids can be prescribed when Lermit sign is present. Finally, motion sickness medication may assist some MS patients with vertigo and dizziness and the associated nausea they experience as a result of inflammation of the CNS pathways associated with the inner ear and balance.